Well, thank you very much. It's really my pleasure to introduce myself and the other two folks that are going to participate, Dr. David Buckhalter and Dr. Sri Derbakala. And my job here today is to really introduce you to, handheld precision guidance technology for direct anterior total hip replacement. And it's great to see everybody from Mexico and Argentina and California and South Carolina, so keep those coming. And we'll try to, as Jennifer mentioned, we'll try to answer everything and get to almost everything if we possibly can in a timely fashion. So welcome. The first section is dedicated simply to HipAlign and where have they been and where are they headed. And I'm going to take you through that, and then we can direct some questions toward myself or Dr. Buckhalter or Dr. Derbakala throughout the talks. So the origins of HipAlign really began from the total knee technology. And that's something that has been out much longer than direct anterior HipAlign. And with accelerometers, gyroscopes, to provide accurate acetabular component placement, accounting for pelvic tilt, and displaying leg length intraoperatively, so there's direct feedback intraoperatively. It doesn't really tell us where to go, but it does give us a direction. It doesn't make us go anywhere specifically, but as you all know, we try to get our acetabular components within the safe zone every time. We're not always successful, but this is helping us out, and it should help us out become much more specific for specific patient needs. And so, as stated, this started from the knee technology, which is well proven, and it's true, and it's been articulated in the literature time and time again to be quite accurate. The HipAlign system is similar in that it takes the pelvis into account and the pelvic tilt, and it allows us as surgeons to get the components into appropriate positions throughout the case and into that safe zone for the acetabulum and to within a couple millimeters on the leg length. What HipAlign does for surgeons is it gives us value. It gives us clinical value. We're able to navigate that cup placement. We're able to assess intraoperative leg length, and we know immediately what we need to do if we're off to correct things. And that's the beauty of direct anterior hip replacement, but can we get any better? And that's what HipAlign allows us to do, to chase perfection. We're never going to be there, but we're going to try to get there, and this helps us. It's very, very simple. It integrates into a standard workflow. None of us want to be buttonholed and changing our workflow. This is included into the standard workflow, and it doesn't change our intraoperative workflow. It's handheld device, which is in a sterile field. There's really no preoperative imaging or preparation. It virtually eliminates the need for lead, which all of us direct anterior hip surgeons would want. It's very equivalent on its accuracy to handheld, or large console or quote-unquote big box navigation. And what we're trying to do is create postoperative radiographs that look the same every time. So we're reducing those outliers and increasing our accuracy. Just a couple slides taken for our first 100. You can appreciate the Lunik safe zone here, and our first 100, and this is within the learning curve, and you appreciate on the left, as you look at the screen, HipAlign, everybody is within that Lunik safe zone. If we look at Dr. Dome's study in 2015, we can see with fluoroscopy and direct anterior hip replacement, it's really striking that there's a significant amount of outliers. So it's quite obvious that we are making progress creating more accuracy with our acetabular components into the safe zone. Now, on top of that, not only can, with this technology, can we get our cup position accurate, we can also get our leg length accurate, and we can assess that intraoperatively. The target leg length was approximately 5 millimeters, and what we found is that 94% of the time we're within 5 millimeters. 84% of the time we're within 3 millimeters of the appropriate leg length, or what we're shooting for. Because if we don't, we all know orthopedically that leg length can cause significant issues, not only with the patient in the long run, with a sore, deformed spine, a back, pain, revisions, patient dissatisfaction, and unfortunately, lawsuits. I think that the value of this is maybe somewhat understated because with other approaches, it's very, very difficult to get appropriate position of the pelvis during surgery, and it's very, very difficult to get immediate feedback. And what OrthAlign has done for us, direct anterior hip surgeons, is once again give us that immediate feedback to fine-tune what we thought was good to make that better. Also, I found in my own practice that, most direct anterior hip surgeons really don't want a significant amount of fluoroscopic radiation. We don't love utilizing lead on a daily basis. Not only that, we really find it difficult because you really don't know who's standing across the table operating that C-arm. Is it a new tech? Is it a student? Is it an experienced tech? Well, those folks can really make or break your day. Not only can they make or break your day, they can add a significant amount of time to each surgical case. So this is just a little bit of data that I pulled myself out of a series of 50. And I looked at C-arm time per case with the OrthAlign plus HipAlign units and without it. And without it, I was about 17 seconds. With OrthAlign plus, I'm tracking at about 5.3 seconds, which is about a 70% decrease in time per case associated with C-arm utilization. Initially, when I started using the HipAlign, I was about 5 minutes longer per case. Now I'm decreasing my surgical time by 12.6 minutes. So what it does, it's not only adding accuracy to the case, it's allowing us to decrease the radiation exposure, i.e. the things that go along with that, potentially radiation-induced cataracts, carcinoma, and it decreases surgical times so everybody can get out at the end of the day, or we can add further surgical cases at the end of the day. So yeah, real life lead apron. Yeah, if everybody remembers the movie, huh? Great movie. So the system components are these, and they're very, very simple. They're not unlike the HipAlign units that we're all familiar with. There's a navigation unit. There's a reference sensor. There's one tray of instruments, and it's an easy setup. And I know Dr. DeBacala and Dr. Buckhalter are going to talk a little bit more through that here at some later slides, so I'm certainly not going to take their thunder, but it's interesting to understand. The technology is very, very high-tech. The engineers that sit on the backside of this amaze me on a daily basis, but the accelerometers and gyroscopes are second to none, with wireless communication throughout and complex algorithms which figure out pelvises and hip centers and knee centers, etc. So all the same technology with NeoLine and HipAlign. So it's pretty simple. What OrthAlign has really tried to do is not add difficulty per case and not increase problems that arise with increased difficulty. We all know that the automobiles that we had 15 years ago, we could change the oil and do all the maintenance ourselves, but not anymore. And what OrthAlign has done here, they've taken it back a few steps so we can actually change the oil ourselves. So they're giving us the tools that we need to do better, but we certainly don't have to read from a manual to figure it out or have anybody special in the room to allow us to figure it out. This is a simple visualization of what HipAlign is for the direct anterior approach. It's two 4.0 millimeter pins in the ipsilateral iliac crest, a mounting bracket, a computer, a sensor, and a probe. So quite simple, and nothing to get in the way, nothing to confuse the back table, and nothing to make it difficult. The system inputs are these. Initially, we will take, once everything is mounted, we will take a table registration. So the key here is to make sure the table is level with the floor and level the probe with the patient in the table. So this probe gets a visualization of the longitudinal axis of the patient intraoperatively. You can appreciate that with the blue lines. This is such a simple procedure, and the nicest thing about the accelerometer is it gives us an axis based on gravity and the horizontal plane. It's all related to the vertical pull of the gravity, and it establishes the vector. And I'm not going to go into the specifics of it, but it's certainly above my pay grade. But it works extremely well, and the simplicity of the system allows us to go through it step by step by step by step. And it takes a very little amount of time to do this particular procedure. This system gives us a quick snapshot of the anterior pelvic plane once we register our landmarks. And those landmarks happen to be the ipsilateral, contralateral, anterior superior iliac crest of the pelvis, and also one point on the pubic symphysis, and then finally a point on the anterior aspect of the femur. This gives us a starting point, so we still have to perform some preoperative templating to understand how short or how long our operative leg is, i.e. the difference in length, to try to match that. That's not going to stop being a part of total hip arthroplasty. Then we can push forward with obtaining a TAC registration, and we can judge leg length based on that initial starting point and leg length. This is just an intraoperative view of the system as a whole. You can see the mounting bracket, the computer, and on the impactor is the sensor, and that gives us an indication of the abduction angle and the anteversion, which would show something like this. If we want any further information, this is very simple. It gives us that abduction and anteversion angle. It also tells us intraoperatively what the pelvic tilt is. If we want more information, we can find that. You don't necessarily have to enter the more information screen, but we can certainly find that. And then it gives us a true APP reference plane along with the coronal reference plane. And this is a mix essentially between, or a hybrid between, the anterior pelvic plane and the pelvic tilt. That gives us the coronal geometry of the system, and the mathematical formulas are laid out to be very, very precise. So what this gives us is something very simple. It gives us the reproducibility without the capital expenditure of big box navigation or robotics. And you can appreciate from these 5 slides that they're all different patients, even though they look the same, but this is exactly what we're trying to do, is be reproducible at whatever abduction angle you want to be at and whatever anteversion you need to see to make the hip stable, along with creating appropriate and equal leg length.